and kind of, because I just started it, I wanted to start something, but it inspired me to keep sharing my story and sharing my experiences and looking for opportunity. And there was one thing that I learned is that when your heart is open to doing something, the world around you will push you further and attract you towards what you want. And that was when I had contact with the Education Saves Lives campaign. They were looking for stories to inspire action by the government. And then I was so excited. Though people around me were like, why are you going to share your story to the world? Isn't it something you need to keep very sensitive? But deep down in my heart, I wanted to share my story because I knew that I was going to be representing the voices of other people like me who were not bold enough or who did not have the capacity to share their stories. And then with the Education Saves Lives, I shared my story, and I also had the opportunity to listen to the stories of other young people who had been through female genital mutilation, teenage pregnancy, GBV, and issues like that. And one thing that I found was, it was very peculiar because we're all youths, but this experience did not start with us as youths. It started when we were way younger. But somehow the realization and the effect were felt much strongly when we became youths. And so that was one of the major factors that I discovered in that experience. And I wanted to keep following through and keep representing my community with the campaign. And phase 1 happened, and it went on to the phase 2. There was an endorsement on the WCA commitment for educated, healthy, and thriving adolescents and young people. And I wanted to keep working in that sector. And I also found another opportunity with Global Fund for Children because I also wanted to work in multiple sectors. And there I was able to work with the Africa team back home with adolescents and children. And I can go on, but this experience that I had has kind of attracted me to opportunities to give back to my community, not just from started with my podcast, but not just from there, but also in other multiple sectors. And I also, there's something that I decided it inspired me to do as well. Having these experiences with a global platform, regional platform, national platform, I decided to now scale up the podcast by starting a foundation, which I did last year, to also share these stories and experiences in the ways that can influence these young people. How they learn is different, how they communicate is different, how we can influence them is different. And so with the foundation, my vision was to share stories and create safe spaces where young people can access SRHR information in ways that they are able to resonate with. And this is what I'm doing currently in my community back home in Nigeria. Thank you.
Thank you. You can pass over to Cyprian.
Okay, thank you so much. First and foremost, my name is Cyprian Naldis Komba from the United Republic of Tanzania. As Andra said earlier, I'm working with the network of young people living with HIV. And also, I'm the lady focal point focusing on SRHR and HIV, particularly with young people, at the network of young people living with HIV. Answering to your question that what has been my experience as young people, as maybe an activist around sexual productive health, I do remember it started way back when I was just preparing myself to just join the university because, you know, I'm from the rural setting, so I was like joining to the big city. I was supposed to move from the rural setting to the big city to just join my university. And for some of us who have been raised by our mom, it has been hard for them to just speak to us on issues around sexual productive health and right. So when I was just preparing to just go, the day before I take my bus away to the university, my mom, I do remember she told me that, please, can you just go and visit someone? The elder, there's a certain elder that we do respect that much in our community. I didn't know what that elder going to tell me, but mom told me that I have to go and just pick something from that elder. I didn't know mom communicated to him, saying that, please, I'll just send my boy to come and then talk to him about these issues around sexual productiveness, around HIV prevention, and so all of those kind of things when he's just joining the university, given that he's coming from the rural area and he's just moving to the urban area. But all of those things, she couldn't just communicate them to me. And then I went to that person. And I said to him that I just came to just grab what mom sent me to just grab. Then he said, no, there's nothing, so we have to talk. Then what are we talking about? Then he started talking about, okay, you are just now joining the university, and you're going to interact with so many, many people, and there are so many things that are going to come up. There are this HIV, there are a lot of things going to happen right over there. So you need to take actions. You need to just prevent yourself of HIV and all of those kind of things. But what I realized right after I've joined the university, the information that they gave me back home was not right, because they didn't know what is really it's happening at the university. You know, I'm sharing this story because I just want to see how it is impacting others. Because you know what? I have not born with HIV, but I've contracted HIV in the long run when I was at the university. Maybe because of this kind of information I got from them was not that much enough, and it was not that much comprehensive about sexual reproductive health and right. If it could have been that comprehensive, and if I could have got that in the long run in my studies from when I was starting the primary school, the secondary school, maybe I could have been empowered that much enough and became resilient, and I could have not contracted HIV, right? So when I contracted HIV, I felt like I'm in the midst of nowhere. It's like it was like a death sentence by the time. It impacted even my studies and so whatever. But it initiated something inside me that's saying how much I experienced the same things like I did. And what should I do to just make sure that maybe I help others, just get rid of these kind of situations that I've been through. And then I decided to just get connected myself to different programs at the university to learn what is really happening around sexual reproductive health, around HIV, and what it takes for a person living with HIV to just live healthy and fulfilling lives. On the course of learning, there is where I came to realize I missed a lot of information. And I came to realize that there are so many young people in the country, or somewhere else, that are also missing the same kind of information I missed. And that's the reason why I contracted HIV. And I was like asking myself, how many are contracting HIV? Because me, just knowing about my HIV status, not because I was falling sick, no. There was a campaign at the university promoting people to just test their HIV. That's why I got them tested. By the way, I was healthier, and I couldn't just accept that. And I was asking myself, how many at the university are living like the way I'm just living, and they don't know about all of this? It's only because they don't have this clear information about what is really happening. This is where I get to join the network. And then after joining the network of young people living with HIV, I was exposed now to so many different programs, and then just learn about it. That's where I just came to realize what is sexual reproductive health, what is comprehensive sexual education through UNESCO. I've been engaged in these Education Plus initiatives, just understand why it matters and why we should scale up this Education Plus, and with the Plus component to make sure that these young people are joining the universities and so whatever, they first remain in school, but they have been getting this component for them to just understand what it takes for them to prevent GBV, HIV, and everything all about. So all of these things, I can say it starts with capacity building. So we need really to just invest on making sure that we just reach young people at the grassroots level, and we have them well informed. They grow up with that knowledge, and then we thrive together. Thank you.
Over to you, Paul.
Thank you so much, moderator. My name is Paul Masimong from Lesotho She Hive Association. It is an organization that strives to combat gender-based violence, especially amongst women and children. So to answer your question, when implementing, we realized that there are a lot of myths and misconceptions around SRHR that impact negatively the access of services by AGYWs to access the services. Also, the issue of religion in our countries, you find out that most clinics that are owned by Catholic churches, they do not accept or allow people to access SRHR services, so meaning that there are limited resources for people that really want to access the services. where we look at the social setting, the issue of SRHR is a taboo, and it really becomes a problem when we want to provoke dialogues or empower adolescent girls and young women on issues of SRHR. The guardians or the parents think that we are promoting sex, not the realization of young people's rights. Yes, and this leads to lack of information, and you find out that it ultimately results to new HIV infections, unintended pregnancies, unsafe abortions, like to mention a few. Yes, thank you so much.
Good morning once again. My name is Abisha Gwawire, and I work with the Uganda Association of Women Lawyers as a project coordinator, FIDA Uganda. So my very first experience with SRHI, it was also a bit personal. I remember when I was in high school, so you go to like senior six, that's the final class, then you join the university. Like, these discussions about SRHR are really a taboo. Maybe my country, because it's a very religious country, so it feels like, oh, you're encouraging children to have sex and all. And I remember we had a teacher who, so we're in class, because this teacher, we used to call him a joker, because he would joke too much. And I'm sure that is how he was able to pass on that message. So you're in class, and then he's like, oh, by the girls, you're going to the university, there's a drug called Postina. When you have an unsafe sex, make sure you take Postina. That was it. So all of us just crammed the name of the drug. And we reached the university, and you realize, in fact, us now we were the sharp ones because we knew the name of the drug. Very many other girls had no idea what to do. Now you're the one advising them, go and look for this drug, go and look for this drug. And even when you go to like the pharmacies to be able to access this medicine, nobody is going to tell you. No one is going to describe for you what it does, what are the side effects, like take you through that whole information that you need to know to be able to use this drug that you have. And that is the only contraception that you know. That's the only information that you have. And every other girl I remember at the university in my class, that's all we knew. So you know, oh, if you have unsafe sex, just go ask them for this drug and that's it. And people had side effects. Like, when you come and discuss, you're like, oh, it did this to me, but nobody told us about the side effects. And you also realize that in the communities where we are working, that's the story. In fact, for us, we were like that this teacher was able to sneak in that message for us to be able to have an idea about contraception. But you go down to the communities, I'll concur with what he said, people do not have this information. And you cannot openly have these discussions because you're going to be seen as you're spoiling our children. You are encouraging them to have sex when they are still young. But they are having sex, you get, eh? But so why don't you give them this information to be able to protect themselves? So you find that the rate of teenage pregnancy is really high. And people are not, this is not Virgin Mary, that they're just waking up and they're pregnant. You get, they're doing something. So why don't you give them the information to be able to protect themselves, to be able to achieve their goals in the future without that hindrance of, I'm a teenage mom and all that. But because they don't have this information, those who are really bold enough to go to the health centers, you must be a married woman. Like they'll ask you, why don't you come with your husband? I'm not married. I don't want to be first married before I can begin engaging in these activities. But that's not the case. Otherwise, like I said, you're very immoral. I remember another personal experience, not with me. My brother got married, and the day after his wedding, he went with his wife to get contraception. Like, she had just heard of an IUD. So she just goes, oh, give us an IUD. And it was inserted wrongly, and she died. This is the day after her wedding. You can imagine. But if they had had this information like prior, they would have been able to like sit, discuss, maybe do the test, like, okay, this will work for you, this will not work for you, this is more compatible for you. She didn't have that knowledge. And she died the day after, like the day after her wedding. People are still on hangover and they're thinking, oh, the bride has died. You can imagine. So I think we need to do better. Thank you.
Thank you, Abby. Nyambura.
Good morning, everyone. So I'm Nyambura from Q Initiative. So for my experience, growing up, no one ever talked to me about SRHR. The only thing I was told by my parents, stay away from boys or you will get pregnant. And I did a very good job. I stayed away from the boys. Got closer to the ladies, and here we are. So, my personal experience as a recipient of SRHR services, as a queer and non-binary person, the first experience that I got when I went to seek SRHR services, I was around 19 years. You know, at that point, that is the only time now I am going to the hospital alone without my mom. The first thing was, why are you dressed like a man? Why are you, actually I remember there's one nurse who asked me, why are you dressing in your husband's clothing? And I was like, who told you I have a husband? Also, if I had a husband and I'm wearing his clothes, what's your problem? And she got a bit defensive. You know, you're supposed to be respectful and all that. And I was like, I'm not here to talk about my clothing. I'm here to talk about my health. So that has happened severally, you know, facing a lot of stigma, discrimination from healthcare workers. Because most of them, I would say it's ignorance. They don't want to get to know you before attending to you. So as non-binary queer people, those are some of the challenges you're facing. You go to the hospital and now it stops becoming about your health. It now begins to become about how do you have sex? Why are you gay? You know, have you tried men? Have you done this? Have you done that? And at the end of the day, you will find that most people get really uncomfortable and they end up having poor health seeking services. So I joined Q Initiative as a volunteer in, I think, 2016, 2017, around that time. And I was a sexual reproductive health advocate. So I would, you know, offer health education to the beneficiaries. And as years went on, I started now having forums with the healthcare workers, you know, with other stakeholders. One of the experiences that we are having, I come from the North Rift region of Kenya, and people over there are some conversations they don't want to have. So you will go to tell a doctor that, you know, sexual reproductive health and rights, it's for everyone, you know, regardless of their sexuality, gender identity, and everything. And then they will start coming to you with their beliefs, with their cultural norms. You know, from my culture, this is not supposed to be accepted, you know, from my religion. So it becomes really tough to have conversations with some of these people. At some point, some of them, they want now to perform conversion therapy. You know, what if we pray for you? What if, you know, we get you a man? What if we, you know, try to talk to you out of it? And so it becomes a bit challenging. But at the end of the day, we still have to give them the message, you know what, it's not about your religion, it's about me as a person. And it's about you respecting me as a person enough to offer services to me. Also, there's a lot of misinformation among the healthcare workers, and that actually doubles our work. Because we are going to them with the right information, but they have this misinformation that they have held on to for the longest time. So for you to convince them that, no, that is not the right information, then it becomes a really big challenge, but we still, you know, press on and move forward. So basically, I can say, as a queer and binary person in Kenya, SRHR advocacy is not easy, but we are trying.
Thank you. And I want you to remember these are the voices of young Africans when it comes to SRHR, and that's why we want to talk about these policies. And we want to look at the continental policy that it identifies that young people have so many risks, and related to SRHR are what you just mentioned, you know, HIV, AIDS, teenage pregnancies. So I want to move back to you, Nyambura, to say, why is it important that we have young people being represented in these kind of policies?
First of all, I would say that young people are very vulnerable because of the lack of information, because of some cultural norms, some societal norms. that, let's say, for example, there are cultures who are okay with child marriage. There are cultures that are, okay with FGM. So at the end of the day, due to this, it makes the young people very vulnerable. And the moment we have these young people engaged in such forums, then it becomes a very good way to empower the young people so that they know that it's their body, and they have a right and they can say what they want to do with their body. And also, the moment you empower these people, we have reduced rates of child marriage, you have reduced rates of, the FGM cases. Because the moment you empower a young person, this young person will go back home and have conversations with their parents. So through young people, we will be able to bring the parents on board, other stakeholders on board, and we will be able to cater for the needs of the young people. Yeah, I guess I'll stop at that.
Thank you, Yambura, and I want to come to you, Cyprian. The Continental Strategy was launched last year in October, and it's been almost a year of implementation. I want to find out from you, as someone in this space, what 2 gaps have you picked up from the strategy, and how can we fill these 2 gaps for the benefit of young people?
Okay, thank you so much for such a good question, Ontra. First and foremost, I would have to declare this very clear that most of our strategies in African continent or in African countries are very clear, and they provide a clear framework for us to just implement our work. The gap always is the implementation of those strategies. When you look to African Union Continental Strategy on Education for Health and Well-being of Young People, from the first page to an end, it is very clear. It articulates what it needs to be done. It provides it says, it talks about how the strategy was just being established and how it's going to be implemented and who has to do what and where. But the issue always, it has been the implementation. And again, coming back to that strategy that, as we said, it's now almost a year since it has been launched, there's this gap that I see happening in many countries, that whatever we are having a global commitment, or I can call it a continental commitment that are committed by our leaders, we are lacking this, what we so-called localization of that commitment. And whenever we are localizing that commitment, fitting our contextual and the challenges and the challenge that we are experiencing as a countries, we often not take each and everything that clearly articulated there, that it can help us just move forward. And I think we need a bit to change. Maybe we are calling it as most of time a political commitment, and they end up being political as how politics is. So maybe we need to change. We need, I don't know how should we just be do, or which way it can be best for it to call it, because we are calling them political commitment and they end up being political in the way politics are. Another thing that I found, it is the involvement of young people, particularly in the execution of a particular strategies that we are speaking about here today. After it has been localized to a different country where it has not been localized to that extent, how do young people participate in the execution of that strategy, that they can inform their lived experience and maybe offer some sort of recommendation that will help us, whatever we are reviewing the strategies, to say, here we need to shift from A to B because this is not working. Because as young people, and everyone in the room, we know what works, and we know what needs to be done so that we get where we want to be there. But the issue, it has been, like I said, the implementation, so whatever. So the involvement of young people, it should not be looked at a way that maybe we need to see young people, they are part and parcel of the implementation of the programs or the execution of the strategies. But we should go back and see, where are we getting these young people? What are their structures for them to feedback? What are their structure for them to consult and get information to feed the implementations? These are the things that we don't look at all. What we always look is only we have a young person. We don't necessarily look at where is he coming or she is coming from, and how can he or she bring back the feedback to the people he or she is representing. So the involvement of young people is missing that way. But also, we have got this inadequate finance to just make sure that we make these programs executed, or these strategies executed at our country level. As we heard yesterday, our nations are not being even able to pay our own debt. And we are now struggling with domestic resource mobilizations, of which yesterday I've read a lot about it because I was like even one among of the person that pushed for domestic resource mobilizations. But I've not gone dive deeper to just understand how can a country set aside resources for HES while we cannot even manage our own debt. So I thought we have a work to do before just pushing for the domestic resource mobilizations. Again, when it comes to the execution of this commitment, this is strategies. We always don't have resource for it. So we crafted good strategies, we involve different people, we can have fund maybe to just meet to review those strategies, but we are not implementing. To be honest, this is what are happening in many African countries. I was like going through the strategy yesterday, and the other day before, it's like, oh, I was saying if we could have implemented only for 60%, we could have get rid all of this mess around sexual reproductive health and HIV. For sure, if you go and read about it. Yeah. Let me end there first.
Thank you. And I would like to hand over to you, Chidi. In your work, what successful initiatives that have effectively integrated SRHR education into youth programs can you share, looking at your context in Nigeria?
Thank you very much. Like I mentioned earlier when I was talking about my experiences, one thing that I realized is that as youths, we suffer the effects of lived experiences, which usually begins earlier, probably as children, as adolescents, but we do not always recognize. They don't always recognize sometimes at that stage in their lives. And so I'm going to kind of divert a bit to the younger youths, let me call them the adolescents. And I'm using it to paint a picture of what we should be envisioning for the future generations. And so one of the very successful initiatives that I've been a part of is with Global Fund for Children, serving as a Youth Leadership Council member. As I mentioned earlier, I decided to immerse myself into the work that the Africa team is doing with capacity building for the adolescents. And it helped me a lot because I realized that us youths have a role to play in helping them, mentoring them, and guiding them. And that is exactly what I've been doing. They started this project called the Adolescent Influencers Movement, or you can call it the Adolescent Girls Summit, which is like a movement building for adolescents, because the Africa team recognized that adolescents are not carried along in these spaces. We think that they are still very young, they still need to be in class and learn about formal education and all. But these adolescents have the same capacity to learn about their sexual and reproductive health. And so they recognized it and they started to start working with local partners. So in 2022, they began to work with their local partners in Sierra Leone and Liberia to start the Adolescent Influencers Movement. And this movement, we are working with community-based organizations and ensuring that adolescents are part of community-based organizations. So they are learning through giving back to their communities. From that, they begin to get capacity building through the summit. So the summit is usually biannually. They had the first one in 2022. We had the second one in Liberia in 2024. And they are able to scale up from Sierra Leone and Liberia to Nigeria, Ghana, Guinea, Cote d'Ivoire. And I brought some adolescents from Nigeria, took them to Liberia through Global Fund support. And they are able to learn. And the impact of this adolescent movement is that although due to funding restrictions, we can't bring a lot of adolescents in one setting like this, but because they are part of this community-based organization, the follow-up is that they go back and build the capacity of their peers. And we are seeing pictures, we are seeing evidences, we are seeing that they are really taking this up. And one other interesting part of this movement is that it is shaped by the adolescents. The young people like myself and others are serving as mentors and are guiding them in the process, and the adults and partners are also guiding them. But the adolescents know what they want. and they are actually giving back to their communities. So this is like a very special forum where adolescents are taking up spaces in SRHR. And we have a group, we see what the adolescents, they have the capacity to lead these initiatives, and they need to also be part of these sort of forums and spaces as well. And so this adolescent influencers movement is going to also happen in 2026, but it's not just about the event, it's about the processes that are following with the event. So we are trying to scale up in a Francophone country in West Africa, where we are going to bring more adolescents from West Africa, and then we're also going to scale up to East and Southern Africa. And then by 2030, we are hoping to do an AU continental summit for adolescents. So in this opportunity, I've been able to see how youths like myself are serving as like influencing the adolescents. And what I recognize is that if we're going to have a future where young people are taking up spaces and all, the adolescents have to begin to also take up those spaces, because they will also eventually be youth. And for somebody like me who just began to learn about my SRHR at the age of 23, I don't want that same thing to happen to an adolescent. It will make more sense if they're able to learn as early on as possible, and also help their peers to also learn about their SRHR. So we are envisioning a future where they're also taking up these spaces early on, so that they can have improved health and they're able to live purposeful lives. Thank you.
Thank you, Chidi. It's great to see that we are all making contributions in our spaces towards the continental strategy, despite the gaps that Cyprian has identified. Now we come on to the Addis Ababa Declaration, which reaffirms different protocols and strategies that we already have in Africa. We have it reaffirming the Maputo Plan of Action, the Abuja actions towards elimination of HIV and AIDS, and the policy that we just mentioned. So I want to come to you, Abby. This declaration was launched in 2014. That is 10 years ago. What progress has been made in terms of achieving the targets in the declaration?
Thank you. So, one thing you need to know about African countries, one of our, I want to say excuse is we don't have money. Right? Like, I have read that declaration. It's very good. And like I said, like most of our laws, they're very clear. I declare we shall do this, I'll do this. But when we come home, I don't have money. That being said, of course, there are countries that have really worked with whatever resources they have to make sure that they are able to achieve some of the things that they signed to do. But if you are to make a comparative analysis, that's like 10% of the work in the declaration. So let me focus on pillar 1 and 2, that is dignity and equality, then health. So one of the things is poverty, reducing poverty and inequality. And it has so many components in it. But you know, most of the problems that we face really stem from poverty. And so when I was reading this thing, my friend, I was laughing. So they were saying, as leaders, we are going to do our best to ensure that they reduce the gap between the rich and the poor. So I was laughing and I was telling my friend, like, can you imagine our leaders signed to this, but are the ones who are doing the most to increase the gap? You can imagine. And then also when you look at gender inequality, and this is big, economic, psychosocial, physical, education, and all that, you find that women have always been disadvantaged. Like, even if we try to work to get to that level, we are still at a disadvantage. We don't have the power like the men do. So it's a bit challenging for a woman to like even speak up in a space. Our governments have really tried to be intentional to create like leadership spaces for women, but these women are not educated. In my country, for example, like in the villages, we have like councils, but the language is English. But you're coming to a village where somebody maybe dropped up in like senior 4 and they only speak in their mother tongue, and you expect them to come and meaningfully engage in English that they can't even speak. So that means you've already cut them out. So they're just going to come and sit like flowers, then go home, get the money, that their allowance, and that's it. They won't have any meaningful result from that space. When you look at health, contraception, like contraception should be available to everyone, and with all its components, access to information. Even somebody in a rural community down somewhere there in Tanzania, they should be able to go to a health center and have this information given to them, and they decide, and all these options are available to them. Governments don't really spend a lot of money on contraception. Like, it's a luxury. So only those who have the money to be able to access this in the private hospitals, which are very expensive, are able to have it. But people down there who don't have this privilege don't have access to this. And then we start saying, oh, pregnancies are high, there's high fertility rate in Africa. So if you're comparing us to Europe, the European countries have access to contraception, which we don't. So you're going to end up saying, oh, African women are very fertile. You're getting my point, yeah? Like, we are not doing much to have these services readily available. When you look at diseases like HIV, AIDS, malaria, tuberculosis, these were talked about, and they were saying neglectable tropical diseases. And they did something like malaria. Sometimes I'm like, how are we still dying of malaria? Like, we know the cause. Some governments have really tried. In my country, my government tries to give out mosquito nets. I think if you go in every household, you will find they have like 10 mosquito nets, even if you're like 2 people. Like, that's one thing they have done. So I really commend my country for that. Some have really tried to make ARVs free, like you don't have to pay to access ARVs. They've tried to disseminate this. But if she were giving me that information like I needed, like him, to know or to protect myself from contracting HIV AIDS, I need to do this and this and this, we won't get to the point where we need to have ARVs. Because if you do not have this information, then you're going to have to make mistakes, right? And you know, some mistakes, you cannot undo them. You get my point? Yeah. So we just need to have more information. Like, our governments need to do better. The laws, the policy is really glaring. When you look at education, it's one thing to say, I'm giving you free education. You have built a structure without desks, without a teacher, and kids are coming without even a book. And then you go and say, oh yeah, we have free education for all, which is the case in very many African countries. Like, if you look at the government-funded schools, they're in a very deplorable state that you can't wish even for your child. A child rather goes to the garden to dig, because they're going to do nothing at school. The schools are not well funded. Yet our military budgets are like 5 billion, and you find education is 100,000. Like, make it make sense, right? Like, if you have signed to these declarations that you made yourself, we didn't force you to make yourself, like, why don't you live up to them? I remember I was having this discussion with a friend some time back, and it's like, oh, our government has done UPE, they've given us UCE, like, you can go and access education. And I remember telling him, like, have you been to UPE? Because somebody who implements, you get to go to the communities often. And I remember I had gone to a school, and the kids were under a tree. So if it rains, we're not going to study that day. You find that desk, which ideally should have 2 pupils on it, it's occupying 5. So that's it, like this, because they all want to sit on a desk and attend to a teacher. The teacher is coming at 10, class begins at 7, it's coming at 10, then break time, because we can't afford you a snack, you have to run back home, walk your 5 kilometers, go get your cassava, then come back. It's 2, you get. And then you're expecting these children to sit the same exam as somebody who is in the city, the privileged children, right? Like, if you're providing a service to the people, like, give it the best. If not, don't. Let's know we have no free education. Let me work hard to take my kids to a school I can afford, right? Because now I can't compete. You're getting my point? Yeah. Let me stop there for now.
Thank you, Abby. And now to you, Mpo. Looking at this declaration, how can young people advocate for the prioritization of SRHR issues within this framework?
Thank you so much, moderator. You know, advocacy is simple and easy when you understand what you are advocating for, or when you know what you are advocating for. So as young people, we need to firstly understand the declaration by familiarizing ourselves with the commitments that are there that speak to youth and SRHR. and also healthcare services in general. We can then move on to awareness campaigns to other youth, raise awareness on issues of SRHR, because as we mentioned earlier, that young people, we do not have information about issues related to SRHR because mostly in our societies it's a taboo. Then we can then build partnerships with development partners because they have influence to actually make things happen. They can actually assist us and strengthen our advocacy. We are also very powerful on social media as young people. We can use it to strengthen our advocacy. And lastly, the declaration stated that it commits to transparency and accountability. We need to hold people that are implementing accountable so that we see progress. Thank you.
Thank you. Thank you so much. And now, colleagues, as we go to the peak of our discussion, I want to just hear from you. Always talking about the importance of meaningful and inclusive youth participation and how key it is when it comes to policies related to SRHR. So now when we come to the acting and the doing part of it, what I'd like to find out from you is for such strategies, for regional strategies of this nature, how can young people be involved in the development processes at country level? Because we find them when they're already done at a regional level. But when we get into the countries, when we go to Nigeria, Tanzania, Lesotho, Uganda, and Kenya, how can young people be involved in those development progresses? So I'm going to start with you, Nyambura, and then I'll end with Shidimba, and then we can have maybe time for 1 or 2 questions.
Thank you for that question. How can young people be a part of the strategies and the processes? One thing I can say is the young people need to participate in the formulation and implementation of the policies that are SRHR related. Because we as the youth, we know what we want, we know the issues that we are facing, and I believe that within us, we have the way forward that will help us deal with these issues. So we should be allowed, or rather we should demand, to sit on those tables when they are strategizing, when they are formulating the policies and when they are implementing them. Also, I believe that implementing someone else's idea is always a very hard task. So let us come up with the idea and implement it. I know they always say we're young, we don't have the experience and everything, and they were also young at some point. Let us make mistakes and then we will learn from that. And at the end of the day, we will be able to achieve what we want to achieve as young people. The other thing, one of the ways that we can also do this is through engagement. Through CBOs, NGOs, youth councils, where we as youths come together, talk about the issues that are affecting us, and then we can have representatives who will now go and have collaborations with our governments on how to tackle the issues that the youths are facing. Thank you.
So, for young people, I think people who come up with these strategies, they just really need to be more intentional about involving young people. And when you're involving young people, don't just get, for example, me, like I am privileged, like maybe I can have access to these spaces, but when I speak, I want to speak to my experiences. I'm not going to speak to an experience of a teenage mother down there in a village who has never gone to school, right? So they need to be intentional about reaching all young people in their different diversities to get their voices and have them included. And then also let them share this information. These policies, especially like AU, I know some AU people here and I'm not really attacking you, but you find that these policies will come out 3 months, you will go on the website, recently I was on the AU website, unless I was on the wrong one, it had not been updated, like over since 20 when. But you want to get this information, it's not available. You never get to know that these processes are happening, and that you can give your input. It comes late when it's done. Well, we had a declaration last year, and you're like, declaration about young people, when? We didn't know about this, working with young people. Who did you consult? You get, they don't consult. So maybe they should try to come closer to the people, come to get our voices, more young people's voices. Listen to us. Like, it's hard to have a policy without my input, and you will expect me to implement your policy. Like, if it's not with me, then it can't be for me. That is your policy, not for a young person, right? So you can't claim to know what young people are feeling when you're not a young person. I can't claim to know what an older person is feeling when I'm not an older person. I'll get there and then I know what you are feeling. So you just have to be like, for me it is intentionality and capacity building, even us as CSOs. Can we build the capacity of these young people down there? Don't always just have the same people in the room, because it's going to look nice for your organization that, oh, we have been able to train this person. Yes, you have trained them. Now they can fly on their own to give have these discussions. Now go train other young people in the communities to also come and be able to share their experiences. This is for CSOs, to be able to share their experiences and speak to these spaces when they are available. That's all I want to say. Thank you.
You find out that in my country, in Lesotho, that the most active youth or the most included youth are those that are in the capital city. Young women, young people that are in other far districts or in the outskirts of Lesotho, they are not included. So it is important that as young people, we also fight or advocate that they are also included as we attend these meetings or dialogues where decisions are taken or where implementation about such policies are being taken. So including everyone in all their diversity is important, because we come with different experiences and perspectives, and things that we want are different. So if only a portion of young people are part of the policy implementation or declarations, it cannot be fair, or it will not be fair to others, as it will not be speaking to them or serving them. So being diverse and including each and every one in their region is really important and can actually bring better results for everyone. Thank you.
Thank you.
Okay, thank you so much. Let me let you up. Okay, I'll go straight, and we have said a lot about the inclusions, how we want everyone on board and so on, but I'll put an emphasis on only one thing that we have always left it out, that the structures. You know, you can speak about inclusions, you can have the entire diversity of people that you want, but they are not necessarily representing people you mean to. I might come here as a young person living with HIV, right, and speak about issues around HIV, but that does not necessarily mean that I represent young people living with HIV, because I don't have the structures behind me that are feeding me, or I can feedback them so that we co-create together. So whenever we are speaking about the inclusions and the diversity, we should work to support the structures. That is, as me, Cyprian, coming here, what are the structures behind me supporting me to just be here or just speak on their behalf? I'll give an example of what we're doing in Tanzania. We've got this, what we so-called, let me give an example of what we're doing on HIV. We thought, like, we need to just get information to young people living with HIV, or to the people living with HIV. But also, we need to get their information so that we can create priorities for them, but also we need to feedback them. But how do we gonna do that? The country has taken these visions from so long time ago through the National Council of People Living with HIV, established this, what we so-called the cluster systems. Like, we have the National Council of People Living with HIV, but we have the same the same things at the council level. So we have at least a structure that are starting at the council level, growing up at the regional level, and then at the national level. It is easy even us to coordinate our work. So if we are not going to support those systems and structures, we may keep on having the same people coming, and even different people coming, but they are not necessarily representing people we mean to just reach to. So we should have, we should support these structures. Dear senior citizen in the room, dear different partners, implementers, please, the information is something very key to get to the people. And these people, they need also feedback. It cannot work if we don't have structures, and if we rely only on those big media firms to just disseminate about what we want. If you want to be seen by the donor, talk about your work on BBC and CNN, but you will not reach the people that you mean to. If you want to get those people, go to their community. They have their community radios. You can have them head. This is how we have to just think of doing development differently rather than doing as usual.
Thank you. Chidi, you can wrap it up for us.
Thank you. I think we have the same idea, but I just want to buttress on what he spoke about. And what I want to say is, yes, we have these strategies, and we have young people who are representing different groups. But I also think that with this strategy, the problems that it's trying to solve is interconnected. And so we need to also amplify our voices. And one of the ways we can amplify our voices is, although we are diverse, yes, we represent different people, but we also need to come together and unify our voices and use that one strong voice to reach the decision makers. Because sometimes we realize that when we go to decision makers, you are going there to talk about your group, the people you are representing, this is the issue, and then somebody else goes to those decision makers and talking about their issue. So it's kind of, yes, it's diverse, but we can also form movements where, as a country, we know that when you're talking about SRHR issues, which we have a lot of issues, these strategies are trying to solve all these issues. We can come together and have one strong voice and say, we are going to these decision makers, this is what we want as young people in our country, and we want you to solve this problem for us. They know that, yes, you have different issues that you're trying to solve, but you're coming with one voice, and they're able to pay attention to you. And also, we have young people who sometimes they see us, they are interested, they want to make a change in their communities, but they don't know where to start, because you have to be part of this. You have to do so many things. You want to be in HIV space, you want to be in this space and that space. But if we also have a forum where everyone in all of our complexities and diversities of spaces can also be accessible, it makes it easier for us to have uniformity. And when we are also accessible, so when there is we have skills, we have capacities, we have diversity of skills, we're able to also manage our resources, and we're able to have a strong front when it comes to these strategies, implementing these strategies in our country. So I think also we need to unify these our diverse voices in some form, especially at the national level, and especially with regards to these strategies and the implementation of these strategies at the national level. So thank you.
Thank you. So, distinguished delegates, we had hoped that we would have enough time for questions and comments, but I also hope you understand that these are some of the young voices in Africa, and we couldn't really stifle them, had to allow them to really enunciate what they have experienced when it comes to the SRHR space and how we can improve our policy. So my plea to you is that we try and memorize these faces. They made some brilliant points, so hold on to your points. See how you can find them and mingle with them as the day continues. We also have cocktail night later on where you can interact with them and pose a couple of questions that you may have for them. But for me, my takeaway here has been access to accurate information is really, really important. Reaching out to other young people is really, really important. Checking our privilege as young people, understanding that as we sit in these spaces, there are other young people who are different from us, and how do we reach out to them? So for that, I'd like to request you to join me in giving a warm applause to our panelists for today. They've done a really amazing job. And let's continue to ensure that SRHR is for all. Thank you, distinguished delegates.
can we have pictures for Thank you so much. Thank you so much to this panel. So in our usual style, would have the last series of abstracts that were accepted for this symposium, and would have abstracts coming from Uganda, from Kenya, from Cameroon, another one from Kenya, from Zimbabwe, and would also hear abstracts from a cross-sectional analysis in 4 countries in Africa, one from Zimbabwe and another from South Sudan. And to do that, I would ask my colleague Fallon to take us through the series of abstracts.
Good morning again, everyone. So welcome again to the second segment of the abstract presentation. As Jude mentioned, we have young activists, young researchers, young practitioners, and professionals within the field of sexual reproductive health and right across Africa who will be presenting their work and researches here today. Our first presenter today is hailing from Uganda, and he'll be sharing insights on the positive impact of unconstitutional changes of government on sexuality, education, and gender minority rights in Africa. Please welcome Geoffrey Ochan from Uganda.
Thank you. Good morning, everyone. Geoffrey Ochan is my... Yes, good morning, everyone. Geoffrey Ochan is my name. I worked for Vision for Children and Youth Forum, community-based organization in Uganda, and we did a research on the unconstitutional changes in Uganda on issues related to sexual and reproductive health, and these are our findings. We find that sexual reproductive health and right is challenging in most of the African states, with parents finding it hard to disseminate this information to the children. And the only hope that we have in Uganda is that the school which we are supposed to disseminate this information on sexual reproductive health and right are being restricted by the government. And this makes it very challenging to us, since it is putting our young children into the risk, and there is need for urgent intervention on this. The study aimed to examine the sexuality education policies and law. It also aimed to assess the impact of discouraging sexuality education at the primary level. It also aimed to identify the human rights violations against sexual and gender minorities and raise awareness. It also aimed to propose policy reforms on sexuality education and also aimed to evaluate the effectiveness of advocacy regarding the restriction of primary level sexuality education. And the last one, to aim to explore social and cultural norms hindering sexuality education. Below are the key findings. In our findings, the discouragement of primary level of sexuality education has so far-reaching effects that require immediate interventions. The findings also state that the absence of sexuality education has led to limited awareness of sexual and reproductive health and rights. This contributes to the high rate of teenage pregnancy and child mothers and fathers, especially in the rural setting. It also shows that the unconstitutional changes in law hurt human rights protection, exposing the sexual and gender minorities to discriminations and right violations. It also shows that the changes, the restrictions, this also restricts the civil society organization from advocating for the minority rights, and this limits the ability to address the discriminations and violence. Because once the laws has not been passed, it makes it challenging in disseminating this information. Also, the restriction of sexuality education also hindered access to health care, especially for the HIV, stroke, AIDS preventions and treatment. Next. These are below the recommendations that we have come out with. There is need to advocate for comprehensive sexuality education at the national curriculum with a focus on diversity and human rights. There's also need to conduct national campaign to engage parents and guardians in sexual education. There's also need to provide teaching training for the inclusive education on sexuality at the primary level. We also need to launch advocacy and awareness campaign to foster tolerance and acceptances within the communities regarding the sexuality education. There is also need to engage parents and the community leaders. Okay. There is also need to engage the leaders to dispose the misconceptions about the sexuality education and the traditional norms. We also need to collaborate with the international partners to establish support network for sexual and gender minority rights by promoting inclusivity, rights protection, and education enhancement in Uganda. We also need to promote peer-to-peer learning programs on SRHR. And the last one, we need to support research initiative to collaborate data and dissemination of human rights violations faced by the sexual and gender minority by providing evidence for advocacy. Below are the references you can click in and it gives you more details. Thank you so much for listening, and I say this God for God and my country. Thank you.
Thank you very much, Yota. Your research and its findings are very crucial and timely, and you've buttressed also the importance of collaboration as we've discussed earlier, the days that have passed. We now welcome Nyambura, who will be talking on addressing SRHR needs of the LBQTGNC persons through inclusive services. Welcome, Nyambura.
Good morning once again. My name is Nyambura and I'll be presenting an abstract. This is a program that has been running in Q Initiative for a couple of years, like 4 years. So for us to get to this point, we had several conversations with the LBQTGNC persons. That is the lesbian, bisexual, queer women, transgender men, and gender non-conforming persons who were assigned female at birth. And we realized that most of them had poor health-seeking services. And this was due to the fear of facing stigma and discrimination from the healthcare workers. I remember I mentioned during my presentation that most of these healthcare workers treat the queer community with a lot of stigma and discrimination. And we also realized that most of our target population had limited access to information on SRHR needs. We, as Q Initiative, we conducted county entry meetings. This is whereby we went to the health facilities and we conducted sensitization forums with the service providers in those facilities. Mostly we had interactions with the people who are in charge of that facility and also the clinical officers and the nurses. And after we had these forums with them, we told them the needs of the LBQ TGNC persons. And later on, we went ahead to conduct enriches in these facilities, whereby we would mobilize 15 persons per month in every sub-county. In Uasin-Gishu, we have 5 sub-counties. So in every month, we would reach out to 75. Is it 75? Yeah, 75 persons with different services like breast cancer screening, cervical cancer screening, HIV testing, and also other components of SRHR. Next. So these are our findings and the lessons that we learned. We realized that there was a knowledge gap by both the LBQ TGNC persons as well as the healthcare workers. You find that Uasin-Gishu is not that so urban and it's not so rural, it's just in there between. So most people did not have information. So we, and most of the LBQ TGNC persons were not aware of the components of SRHR, and that made them have poor health-seeking behaviors. And this is also coming from the fact that in our African culture, most families do not talk about SRHR. So by the time you're reaching maybe 18, 19, because we deal with people over 18 years, you have very limited information about SRHR. When it comes to the healthcare workers, they had less information in matters of gender and sexuality, which made it difficult for them to offer stigma-free services, as they had not undergone sensitization forums on how to handle the LBQ TGNC when they visit their health facilities. So like I had mentioned earlier, most of these people, when you visit them, they will always come up with their personal beliefs and their cultural norms and everything. And at the end of the day, when they're offering their services to you, they will not offer quality services to the lesbian, bisexual, queer women, and the transgender men and non-binary persons. So to conclude, and for the next steps, for us to achieve good health-seeking behaviors among the LBQ TGNCs, we need to conduct advocacy forums and CMEs for healthcare workers to educate them more on LBQ TGNC matters. So you find that the people that we had these forums with, the people that we have sensitized, maybe we sensitized them on, the ones we sensitized last year, maybe most of them have been transferred to other facilities. So at the end of the day, we are going back to the drawing board because now we have new staff coming into health facilities. So that means we need continuous advocacy forums with them. And lastly, we need to conduct gender forum workshops for the LBQ TGNC persons and educate them more on SRHR matters so as to promote their health-seeking behaviors. So we realize that most of the time when people are joining, maybe they're becoming beneficiaries of Q Initiative, they have very limited information. For example, I can speak for myself. When I joined Q Initiative in 2016, I had very less information on gender and sexuality. But with time, I attended several gender forums, and I was able to get more information in regards to sexuality and gender orientation. And so as Q Initiative, we feel that this is something that needs to be continuous because we have new beneficiaries joining us. We have young people who identify as the LGBTQ community joining us, and they have very less information. Thank you.
Thank you very much, Nambura. Thank you so much, Nambura. Your presentation on addressing the needs of LBQ TGNC person, it's very, very enlightening and very timely, and we've also seen that there's necessity for healthcare providers to be trained in this domain, offering services to these persons. Thank you very much. We now welcome Brenda Ngwa, who will be bringing perspectives from Cameroon. assessing knowledge on the importance of using the hotline among young people in Buea, Cameroon. You're welcome, Brenda.
Good morning, everyone. I'm called Manka Brenda, and I'm from Cameroon. I work with Vision in Action Cameroon. So Buea is a crisis-affected area where adolescents and young women face challenges accessing sexual and reproductive health due to the crisis, maybe due to stigma, judgment from the health providers, and lack of youth-friendly services. So I'll be presenting an abstract assessing knowledge on the importance of using the hotline. We actually run the hotline where it provides sexual and reproductive health information to adolescents and young people in Cameroon. So in Africa, the lack of information regarding sexual and reproductive health is prevalent among young people. And this study was conducted by Dong et al. 2017. So access to accurate sexual and reproductive health information is essential for individuals to make informed choices about their well-being. However, hotlines serve as a vital resource in sexual and reproductive health emergencies or crisis situations. Whether someone is facing a potential pregnancy, seeking advice on contraceptive methods, or experiencing sexual violence, hotline provide immediate support and assistance. Please, next slide. Next slide, please. The objective of this study is to inform young people how hotlines can be used to access sexual and reproductive health information, report emergencies, abuse, or unsafe situations, contributing to their overall safety and well-being. Next slide, please. An online cross-sectional descriptive study was undertaken through WhatsApp Messenger among some young people in some selected communities in Buea. The young people aged 18 years and above constitute the study population, and a pre-validation questionnaire was used to collect the data. This questionnaire was backed up weekly and was stored in a flash. According to the findings, a total of 1,902 adolescents and young women contacted the hotline. Among these people, we had 1,686 girls and 215 boys who called the hotline seeking for information on sexual and reproductive health. Among these participants that called, the majority were young people aged 18 to 25 years who called seeking information on the WHO protocol on safe managed abortion, followed by information on STIs and menstruation. According to the findings of this study, it suggests that continual provision of hotline information is crucial among adolescents and young women in Buea. By providing accessible support and guidance, the hotline can contribute to improve and promote preventive and therapeutic practices related to sexual and reproductive health issues. This proactive approach can empower individuals to make informed decisions, access necessary resources, and ultimately enhance their overall reproductive well-being. Thank you.
Thank you very much, Brenda. It's very true, the importance of hotline in crisis areas cannot really be overstated. Thank you for that research findings, Brenda. We'll now welcome another presenter who will be sharing perspectives from Kenya, assessing contraceptive uptake and continuation among women and girls who self-use medical abortion. Results from PAMAC Adaptive Learning Phase in Nakuru County. Please welcome Steve Sigo.
All right, check 1, 2. Good morning, everyone. I hope you're all doing well. My name is Steve Biko. I work at IPAS, where we support access to contraception after self-managed abortion. My presentation will basically highlight our work in terms of supporting access to post-medical abortion contraception through our interventions at community pharmacy. Next. All right, so PMAC is post-medical abortion contraceptive project. Currently, we seek to develop scalable, evidence-based interventions that increase uptake and continuation of contraceptive use after self-managed abortion. The figure beneath presents our design processes, which integrated human-centered design approach and market system development approach to craft interventions responsive to the needs of women and girls. It also highlights our implementation approach, which borrowed largely from adaptive learning approach, and finally, our evaluation approach, which was research focused. And also the respective timelines in terms of when each and every strategy was implemented. Next. All right, so the 4 solutions are basically product of our design work. So I'll briefly just discuss them, starting with the price solution. So price solution was more like, the price solution was more like supply chain strengthening strategies geared towards improving access to contraception and also making contraceptive services affordable at a pharmacy level. Our second intervention was promotion solution, which integrated peer education and social behavior change communication to build knowledge in terms of contraceptive use and empower informed decision making with regards to contraceptive services. Our third intervention was place and product, which was basically a digital marketplace to connect pharmacists and women and girls who are seeking healthcare services, specifically contraceptive services. Our last solution was the provider lever, which brought together pharmacists to co-create a standardized contraceptive service delivery package to be able to support uptake and continuation of contraceptive. Next. All right, so this is in a nutshell some of the learnings, though high level, for each and every intervention that we implemented. Again, I'll start with the price solution, which was very effective in terms of strengthening supply chain processes at the pharmacy level, ensuring that pharmacies had a safe stock level. But again, the low business acumen of the pharmacist limited their ability to plow back the gains from savings to be able to grow their business. The second solution, which was the promotion lever, we realized that the community mobilizers were really effective in terms of pathway to access to medical abortion, but then their inability to provide personalized counseling really crowded out their effort in terms of supporting contraceptive use after self-managed abortion. The third intervention was the product and place, which was a digital intervention. We saw a steady rise in terms of use, given its interactive nature and also informative nature of the platform. But then pharmacists being really profit-driven, they needed the intervention to demonstrate a stronger business case so as to establish a value and support its adoption. Our third intervention was able to usher us to note that providing training to pharmacists, supporting an effective business case, and also developing a service delivery model for them is very critical in terms of sustained contraceptive service provision through pharmacy channels. Next. So all that learning led us to developing this final intervention package, which emphasized on 3 very critical aspects. The first aspect is enhancing quality of care. So here we are looking at training pharmacies, providing routine technical support, and also strengthening documentation so that we can see how this effort is contributing into addressing the public health need. The second critical area was building a business case. We know that the continuity of these interventions depend on the pharmacies being able to open their shops. So developing a compelling business case will be a compelling business case in terms of investment on FP would be able to ensure sustainability of this intervention. And then lastly, to be able to keep this momentum, there is need for us to advocate through advocacy activities, just in terms of strengthening the government stewardship of public health services, especially on the other side of the private sector. Next. So what are we currently doing? We are implementing the enhanced provider solution in about 28 pharmacies in Nakuru. We are also evaluating the comparative effectiveness of this intervention solution. We've introduced another county by the name Kericho, which is acting like a control county to us. And this evaluation is looking at three very strategic outcomes. One is the post-medical abortion contraceptive uptake as our first outcome area. And then second outcome area is post-medical abortion continuation, which we are looking at from the 3rd month and the 6th-month continuation rate. And lastly, we are looking at the overall experience of this client with care delivered within a pharmacy channel. We are also evaluating the technical efficiency of pharmaceutical business to build a compelling investment case for post-medical abortion contraception through pharmacy channel. Thank you very much. Big thank you to Men Engage for granting me this opportunity to disseminate. The project is constantly releasing learnings, so stay in touch with us through the email address there so that we can share some of the things we are learning around this. Thank you very much.
Thank you very much, Steve, for sharing such insightful findings from your project. These are really critical aspects of reproductive health management which you've shared with us, and we appreciate the valuable work you've been doing. Next on the stage, we welcome Esnara Prudence, who will be talking about intersectionality of climate change and HIV prevention. Hello, Esnara. You're welcome.
Good morning, colleagues. My name is Esnara Kativu. I'm from Zimbabwe. I'm representing an organization called Shamwari Mwanaskana, which is a community-based organization that seeks to protect, promote, and advance the rights of the girl child. We also work with men and boys as allies. So today I am going to share with you a scoping study that we did to understand the intersectionality of climate change and HIV prevention for adolescent mothers in the farming settlements of Chiota during the El Nino drought that we are currently experiencing as Zimbabwe. So going to the background of the study, so teenage pregnancies have always been a wicked problem in Zimbabwe, just like many other African countries. And this challenge has been sustained by the limited access to SRH information and services, which is embedded in our policies, our environment, our culture, and also attitudes. So from the beginning of this year, 2024, there have been a record of over 680 teenage pregnancies. So these are the ones that have been recorded only, which means that there is a lot that we do not know about. And last year, one province recorded over 4,000 cases of teenage pregnancies and child marriages. So with climate change, it has always been a contributing factor to the rise in these cases. In mid-2023, it was declared that Zimbabwe will be hit by the El Nino-induced drought, and unfortunately it did. And it was declared a national disaster early this year. This has left the whole country vulnerable, as Zimbabwe's economy is mainly based on agriculture. Then to support this claim, there's a case study that was done by UNICEF Zimbabwe 2021, which indicated that during Cyclone Idai, girls and women were mostly affected and they were at risk of being infected with HIV, with over 1,800 girls and women who were recorded under new infections of HIV in Manicaland province. So why Chiwota? Chiwota has always been a hotspot area amongst our programming areas. But then the nature of the cases that we get from that area really pushed us to want to understand the lived experiences of the adolescent mothers. We had one case of a 13-year-old. We got to know of her. She was already a teenage mother, but we got to know of her because she was pregnant again. So which means that if she did not then get the services that we linked her to other partners for safe abortion, she would have become a mother of 2 at 14. Then in line with this background that I've just shared, we want to understand, I know there was a conversation yesterday around intersectionality of issues. So we want to understand the interconnectedness of climate change and HIV prevention and how it is exacerbating the vulnerabilities of adolescent mothers in farming areas where agriculture is their main source of livelihood, and it has been affected by the drought. So these are the pictures of some of the programs that we do with adolescent mothers and the engagements that we do with community and traditional leaders as well. Next slide, please. So on methodology, the study took a mixed methodology approach to understand the lived experience and the context of adolescent mothers, then to also measure the trends, patterns, and relations. Surveys were used to understand characteristics, attitudes, and opinion of adolescent mothers around climate change, HIV prevention, art adherence. We also used focused group discussions to really get the lived experience of the adolescent mothers and to uncover insights and explore further insights to be investigated with adolescent mothers around HIV prevention. So the sampling that we did, we had convenient sampling because we already have a teen mother program running in the area. So we engaged some of the mothers that we are already working with, and we also, in the community, there's also an HIV support group for girls and adolescent mothers. So we also reached out for some of the participants there. Then with snowballing, we then asked the other mothers to refer us to other adolescent mothers that they know. And we also had an opportunity to engage with community leaders, community cadres, and health practitioners. The study was adhering to the ethics of do no harm, confidentiality, informed consent, and anonymity. And it was also guided by our safeguarding policy. So these are the key findings. 80% of the participants that we engaged indicated that as the result of the El Nino drought, they were severely economically disempowered. So prior the drought, most of the adolescent mothers were doing some projects in the village, in the areas. They were doing vegetable gardening, and there was also subsistence agriculture for consumption. So they had food at their disposal, and through the trading that they were doing with their products, they also had money so they could sustain themselves. But because of the drought, they were affected, and this led to some of the teen mothers resorting to transactional sex, thus elevating the risk of HIV prevention, infections. So for safeguarding purposes, we asked them to just indicate through yes or no if they know someone, if they know an adolescent mother who has now resorted to transactional sex, and over 85% of them indicated they know 1 or 2 of their peers who are now into some form of transactional sex in their areas. The finding number 2, the study found that 3 in 5 adolescent mothers have limited knowledge on HIV prevention, and there are also myths around HIV prevention. So one of the participants actually indicated that as long as I have one sexual partner, I'm not at risk of getting HIV. So this is the information that they have, but they do not know what the other partner is up to when he's not around. So these are some of the gaps that we noted when it comes to information. Then finding number 3, 7% of the young mothers living with HIV are struggling to access medication and adhere to ART. So prior the drought, most of these young mothers had some income generating projects that they did. But because of the drought now, they do not have money. So it's difficult for them to go to health facilities which are at a distance and they need transport. So because of that, it's now a choice of going to get my medication or using that money to feed my child and myself. So this has really affected them, and it then compromises their health and their well-being. Finding number 4, about 87% of the participants indicated that stigma, discrimination, and lack of decision-making power deterred them from accessing HIV prevention methods. So yeah, stigma and discrimination has always been a norm for adolescent mothers. There's a lot of derogatory names that they are called in our societies. And then with the health facilities, I think there was a speaker who talked about the approach, the language, and the term that health practitioners use. It has also been a barrier for the young mothers in accessing HIV prevention services. Then there's also with decision-making power now, because of the vulnerabilities of climate change and all, they do not have the power to negotiate for safe sex with the partners that they have. So they would rather please the person who is giving them food at the expense of their health. Then finding number 5, about 60% of the stakeholders, community members, and young mothers revealed that there is evident lack of SRHR disaster management preparedness for adolescent mothers. Like I've mentioned before, the El Nino drought we were notified of the El Nino drought mid-2023, but nothing was done. It's only after that people were realizing how they were affected by the drought. That's then they started talking about the drought. There was nothing done to prepare for the drought. Next slide, please. So these are the recommendations for the study. Recommendation 1 is to integrate SRH into climate change adaptation programs at all levels. This speaks to us including SRHR into our climate change programs at all levels, from national to community. I know that in Zimbabwe we have a civil protection policy of 1989. It's outdated, and it doesn't have provisions of disaster management and looking into SRHR as well. So there's need to look into that as well. Number 2, community engagements to challenge stereotype, gender norms, and that are affecting adolescent mothers. So there's need for continuous engagements with the community to try and change their attitudes and their perceptions when it comes to adolescent mothers. Then number 3, community-led SRHR disaster preparedness for adolescent mothers. So before we had some initiatives that were used to be done. There was one I know which is called the Durara Mambo, where community members would go and submit part of their grains for in preparation for when there is a disaster. They will then get food when they are hit by drought. So with this one, we are thinking of going back to the way that we used to, taking that Afrocentric approach in addressing disaster, and also incorporating SRHR into that preparedness at community level, giving community members the opportunity to lead their initiatives for sustainability as well. Then number 4, continued information dissemination on HIV prevention and strengthening service provision. Then lastly, we are looking into expanding the study to other areas as well. I think that's it from me. Thank you.
Thank you very much, Esnara. Thank you for sharing your work with us. It really shows how climate change really exacerbates the challenges that we'll now welcome on stage Harry Nebechuku, who will give us a cross-sectional analysis. Okay, we'll welcome Faith. Okay, we'll now welcome Harry Nebechuku. who will give us a cross-sectional analysis of his recent finding from 4 countries across Africa. Welcome, Harry.
Good morning, everyone. Yeah, my name is Henry Nebechku. I'm a postdoctoral research fellow at Demography and Population Studies, School of Public Health, University of Witwatersrand. So the idea behind this research or these studies, having grew up in a family of a father and a mother, and with strict supervision and monitoring. Even when we are sent on an errand, they will monitor the time, maybe give you a time for you to go and return. And also monitor the, assuming you are asked to go and, to fetch water. And they will, when you come back, they would ask how many males or how many female. If it is more of male, or more, maybe you are, you have less male and more of female, is also a problem. So that is the idea behind the research. And having lived in a country or in a community where such strict monitoring and supervision is not there, so we are trying to see if there is any the experience from both sides. Next slide, please. So the background is that we all know that risky sexual behavior among young people is a public health challenge, and data across board has shown that the ill health associated with young people account for the global disease burden. So it was estimated that approximately 90 million new sexually transmitted diseases are reported each year, and the largest share or proportion are to the youths aged 15 to 24. So this is because young people like to experiment, so they usually engage in risky sexual behavior. And this behavior continues to increase the prevalence of STI across multiple societies around the world, and persists especially in sub-Saharan African countries. Next slide, please. Yeah, studies have documented the complex set of factors that constitute sexual and reproductive health problem among young people, such as at the individual level, family, and community level characteristics. So at the household level, the literature has given a clear evidence of the challenges young people from unstable families encounter when seeking to exercise their sexual rights, even when they want to obtain services related to SRH. And cultural, social, religious, and economic factors have all been linked to risky sexual behaviors among young people from unstable families. Next slide. So therefore, understanding the influence of family structure instability on RSB is crucial, especially in developing strategies for addressing the consequences of RSB, and in upholding the objectives of UN SDGs and Cairo 1994 SCPD frameworks. So we all know that a vital component of SCPD framework is to ensure that individuals have access to SRH services, even when experiencing such family structure, even when they are coming from family structured instability. So thus, the study examined influence of family structure instability on RSPs among young people in 4 countries in sub-Saharan Africa. This is a pure quantitative study. Next slide. So the data for the study were extracted from DHS, male and female record. So in 4 countries, Burkina Faso, Gabon, Kenya, Madagascar, and all these DHS, the most recent ones, conducted between 2019 and 2022. So in this study, we looked at 2 risky sexual behaviors, which were multiple sexual partnership and unprotected sex. And the main explanatory variable is family instability, which was measured as both parents alive, widowed, having come from widowed family or divorced or separated household. And we use a descriptive multivariate logistic analysis to explore among the two indicators while controlling for the main independent variables. Next slide. So this is our preliminary findings. From we can see that young people that are coming from both that their both parents are alive, they have unprotected sex. We have 96.7% indicating that they had unprotected sex. So for the multiple sexual partnership, you can see the proportion of those who are from the widowed and divorced or separated family, which you can see that for the widowed, those who engage in multiple sexual partnership are around 37.8%, while those who are from the divorced families are from had 64%. Let's go to the next slide. Yeah, and then across countries, those from Madagascar, from Burkina Faso had the least engagement in multiple sexual partnership, while Gabon and Madagascar had the highest percentage. Next. So this is across gender, and the males engage in MSP more than the females. Next slide. Yeah. So when we ran the regression analysis across the 4 countries, we discovered that young people from the poor household categories had the highest prevalence of MSP, while young people in the average and rich household had the highest prevalence of unprotected sex. So there are higher chances of unprotected sex among those who live in widowed and divorced household. Also, there are high likelihood of engaging in MSP for young people who reside in widowed or divorced household. Next slide. So in conclusion, the findings of this study show that experiencing family structured instability influences young people to engage in risky sexual behavior in the 4 countries that we have explored. So this has significant implications for policymakers, healthcare providers, and advocacy group working with young people, young people's SRH. So therefore, to effectively address sexual rights and reproductive rights of young people across Africa, young people residing in unstable structured families should be the target of the stakeholders in the health and educational sector to promote sexual and reproductive health behavior. This study already won 3-month scholarship at Trinity College, Dublin, and it will be starting from next month. So we are trying to see if we can make it a mixed study to incorporate interviews and FGDs. So thank you so much.
Thank you so much, Henry. Thank you for that insightful presentation and for sharing your findings with us. I'll agree with you that understanding family dynamics and how it impacts SRH are really, we need to understand it so that we can have targeted and comprehensive interventions. We'll now welcome Vincencio, who will be giving us, we'll be talking about driving positive action, advocacy, and social mobilization for adolescents. Welcome, Vincencio.
Greetings, everybody. Thank you so much. My name is Venancio Talarwisa from the International Network of Religious Leaders Living with or personally affected by HIV and AIDS. And our main focus is addressing stigma and discrimination related to HIV and AIDS through comprehensive responses. I'm going to present on driving positive action, advocacy, and social mobilization for adolescent sexual reproductive health awareness through awareness and dialogues in Zimbabwe. We decided to use a congregational response approach. Next slide. This abstract aims to lay out the international network of religious leaders living with or personally affected by HIV and AIDS plus Zimbabwe chapter best practice in advancing adolescent sexual reproductive health rights and within the religious sector. As in Inarela Zimbabwe, we intentionally employed comprehensive sexuality education and information as a winning practice in promoting sexual reproductive health rights, especially among adolescents and youth, as a pillar in the quest to end various sexual reproductive challenges that they confront, including the HIV and STI burden. While comprehensive sexuality education was mostly advanced through the education sector, there has been a huge gap in terms of penetrating the religious sector, particularly the conservative apostolic. Additionally, this abstract outlines some of the strategic interventions that Inerela plus Zimbabwe adopted to promote comprehensive sexuality education and life skills as a way of advancing adolescent sexual reproductive health and rights in the religious sector, and shows that faith-based organization plays a key role in this endeavor. Inerela Zimbabwe's programming and project implementation engaged influential religious leaders in Harare, the capital city, and Mashonaland East. We went to Narira in Chivu to raise awareness and promote congregational dialogues zoomed at boosting adolescent sexual reproductive health rights within the congregations and areas of influence in Harare and Chivu. Next slide, please. The rationale behind the project: Zimbabwe is amongst the countries with the highest HIV burden in the world, where also 70 to 75% of the population attends religious services. So we see that the greater chunk of the population are into religious setups. Although the HIV prevalence has been on the decline trend, currently the prevalence of HIV among adolescents ages 14 to 64 years in Zimbabwe is at 14%, 14.6%, 16.7% among females, and 12.4% among males. This corresponds to approximately 1.2 million people living with HIV, ages 15 to 64 in Zimbabwe. Zimfia 2016. Youth in particular suffer further confront other sexual and reproductive health rights, including gender-based violence, STIs, teenage and unplanned pregnancies, sexual harassment, and multiple concurrent sexual partners, among others. Evidence from various researches indicates that lack of life skills and misinformation are major problems the adolescents and youths are facing, leading them to a myriad of sexual reproductive health rights issues. Sadly, even adolescents and young women continue to bear the burden of HIV and other STIs. Young girls are dropping out of school and are exposed to severe stigma and discrimination. They are not safe because of violence. So the objectives were, we had three objectives: to improve knowledge on sexual reproductive health and rights by religious spaces in Zimbabwe, address social cultural norms and values that affect young people's sexual and reproductive health within the religious spaces in Zimbabwe, and to promote uptake of sexual reproductive health services among young people in religious spaces in Zimbabwe. Next slide. So we developed a policy brief on comprehensive sexuality education, life skills, and the religious sector. You know, when we talk about sexual reproductive health and rights, it's a difficult topic since it's a taboo in the religious setup. So we had to formulate a policy of how to do it in the religious setup. 2 policy dialogues with religious leadership from the Ministry of Health and Child Care and the Ministry of Education. We also held advocates forums to advocate for the inclusion of youth in religious sector in SCE and life skills programs. We trained religious leaders and congregation youth leaders, facilitators, sexual reproductive health dialogue facilitation. And we also conducted additional comprehensive sexuality education and life skills dialogues in Harare and Chivu. We also conducted monitoring and support visits to youth facilitators in Harare and Chivu. Then we trained service providers in Harare and Chivu in youth-friendly services provision. We also provided and sourced then disseminated various IEC materials to promote service uptake. Thank you. Next slide. strategies employed. We engaged religious leaders and youth in church in Harare and Chivu. We collaborated with key SRHR stakeholders within the project community, especially health providers. And we also used a congregational approach because we also know that that's where the youth are. Thank you. This, the results, with the outputs, we had 22 males and 18 female religious leaders and youth leaders reached out to through the advocacy forums at congregational levels in Harare and Chivu. 25 people, 12 males and female community healthy and providers engaged and trained on advocacy for the inclusion of youth in religious leaders. We discovered that we had to work with the health sector. We also had 75 young people reached out on comprehensive sexuality education, life skills, and sexual reproductive facilitation in Harare and Chivu. Then we had 25 sexual reproductive health and rights peer champions. We discovered that when youth work by themselves, the dissemination of information flows smoothly. So we had also 10 congregational support groups in Harare and Chivu, 2 monitoring and support visits to religious leaders, and in Harare, we also disseminated over 1,000 leaflets distributed in youth to the youth in Harare and Chivu. Outcomes: we created an enabling policy environment for youth in religious spaces and congregational level to enjoy their sexual reproductive health and rights. We also reduced the social, cultural, and religious practices that affect sexual reproductive health and rights of the youth in Harare and Chivu. And we also believe we improved the uptake of sexual reproductive health services by the youth in religious spaces and congregational level, though we know that there is a lot to be done since we only covered the 2 provinces. Lessons learned. It was learned that bringing young people together and being able to let them share their experiences and best practices on adolescent sexual reproductive health, rights, and positive impact on the advocacy work in churches and at congregational level. Young people felt safe in their spaces and dialogued easily on sexual reproductive health rights at community and congregational level. Religious leaders have far and wide reach and influence on driving positive change. It's our motto as Inerela Zimbabwe to do positive action. Members of Inerela Zimbabwe were committed to promoting the cause of sexual reproductive health and rights. They have passion, expertise, and influence necessary to make significant impact in our collective effort. We are referring to members that have been trained. Collective efforts and collaborative strategies are key to empowering congregations, strengthen healthcare system, and advocate for policies that uphold the religious, the rights and dignity of adolescents and young people in matters of SRHR in Harare and Chivu. There was lack of inclusivity and equity in programming. More still needs to be done at congregational level in ensuring that needs of marginalized and underserved congregants are prioritized, addressed at congregational level. We also discovered that at congregational level, some youth were being discriminated because of their sexual orientation. Next slide, please. Conclusion: the intervention on advocacy and social mobilization for adolescent sexual reproductive health rights through awareness and dialogue in Zimbabwe in a congregational response approach is a best practice for us. Adolescents and youth who are the target group are strengthening their capacities, their competencies in tackling comprehensive sexuality education, comprehensive sexuality matters, and these youth continue to address these issues at personal and congregational level. Thank you. Tatenda. Siyabonga. Asante sana.
Thank you very much, Vincentio, for sharing those strategies with us. Please, we have one last presentation from Faith Wangari from South Sudan. Faith, we don't have time, please.
I am the last presenter, and I think I'm just going to go like what everyone has talked about. We have learned a lot in this session. So my name is Faith Wangari. I'm Kenyan but working in South Sudan. I work for Alliance for Action Aid as the health manager, and I'm presenting an abstract on integrating SRHR services in a humanitarian emergency context. So Alliance for Action Aid is a non-profit national NGO in South Sudan. It was registered in 2016 and founded by a group of influential elders and health practitioners after we all know the prolonged conflict and the season of flooding. And our focus areas are health, nutrition, but I'll focus on health. Next slide, please. This is my abstract, and I'm also a proud mental health advocate. I worked in the clinical setup for over a decade, and I realized that besides the physical manifestation of disease, we realize mental health is one thing that really makes most of our patients come to our hospitals. So addressing mental health also in SRHR is also very vital. Okay, sorry. Next slide. South Sudan faces complex challenges, that is human conflicts and flooding. And the resultant of this is the physical injuries, the communicable diseases, nutritional issues, gender-based violence, gaps in SRHR, and mental health issues. As a result of the flooding, we realized that many health facilities in South Sudan, they've been submerged by the floods, thereby resulting to inaccessibility of health facilities. As well, most the existing facilities there are located 5 to 10 kilometers, so making the patients not seek health care. Yeah, let's move to the next slide. Yeah, so the gaps in South Sudan mainly are the same in the African context, but most of the health facilities, they are not equipped, and the health workers are not built, the capacity is not built to provide these services. And I've also talked about the submerging of the health facilities, and the government is not able to again renovate and restructure these facilities. There's increase of gender-based violence in women and girls, especially those ones who have been displaced by the floods. They move from their homes and go to higher grounds or in shelters where they are violated sexually. Rape cases are reported, exploitation and abuse, and even the humanitarian actors that provide support to these women also use them in giving, it's like an exchange for food for sex, in other words. And these GBV cases are not reported since these women and girls face fear and stigma. And again, once a GBV case is reported, what we gathered from this community is that this girl who is raped will be forced to get married to the perpetrator, and then the perpetrator will pay a few cows and now take this girl. And you can imagine this marriage will now be on a foundation of rape, which is clearly will also cause mental health to this teenager. We also have teenage pregnancies that are on the rise, cultural norms which do not allow family planning. Women have no say in whatsoever in family planning, the number of children to have. As well, polygamy is the talk of the day here. If you don't have more than a wife, more than one wife, or two, you do not belong. So, and as well, the more you have more wives, and these wives also have other sexual partners, so HIV comes in and sexually transmitted infections. Next slide. Yes, the challenges we have is the funding gaps to really support these women with SRHR issues. I've talked about the STIs, the forced marriages. We do not have female health and hygiene products. That's the dignity kits. And the organization that provide this, they provide just for a short duration. Therefore, there's no sustainability. We also have home deliveries a lot. Women have not yet been empowered to seek deliveries in health facilities, so thereby increasing maternal and neonatal mortality. Next slide. So we have implemented an integrated health model under the AFA program, which is under collaboration with the CHD, that is the County Health Department of South Sudan. And our approach is a community health, BHI, which is a community health worker program. I will not go through all that because we can clearly see. So let us go to the next slide. what I want to really highlight on the impact of this is the training of the young community health workers. We are talking of an age of from 20 to 35, and these community health workers who are young are used as agents of change to the community to provide SRHR information, advocacy, and also messaging. This July, we were able to conduct an SHR advocacy dialogue under Men Engage South Sudan, and it was a learning experience and a participatory approach where we engaged men to know, like, really, where are the gaps and how can we engage boys and men as well. Next slide. So we were able to train 30 community health workers of that age group, and the objective was to understand really what are the gaps in the South Sudan context. How can we engage the men? How can we demystify the cultural barriers as well? And how can we address societal and gender norms in the context? Next slide. So what was seen as that really worked is training as many Buma. When I talk of Buma, I'm talking just like a community or a village. They call it Buma in South Sudan. So using these community health workers, they will again go to the villages, train other agents, and this becomes like a sustainable approach, such that even when the donor walks out of our program, we'll be able to sustain and provide SRHR information. Next slide. So we learned that we still have challenges. There's a lot of cultural barrier in the area, stigma again, the early marriages we have. I met a girl who was as young as 15, married, and very proud talking about her marriage to a 19-year-old boy. And you could see that. And also I met an 18-year-old girl who had complicated delivery. We know with teen pregnancies, again, the reproductive health system is not yet developed, so they will have complications and again losing their infants in most cases. So another strategy that really worked is we were able to engage the local authority, the community leaders, the religious leaders who also went and advocated for change in the community. And with this sustainable approach, we were able to create acceptance in these rural, remote communities. Next slide, please. I have talked about the community health initiatives and the integration of SRHR into primary health care. As a medical health provider, I have noticed that we have not integrated really SRHR into our health facilities, our hospitals, and this is the way to go, like, from here. How can we, besides treating me for a flu, how is my sexual needs, how is my mental health as well, because it is primary health care, then SRHR, and then mental health as well. So, and also addressing financial barriers and creating access to, improving healthy outcomes. Next slide. And the recommendations for us is to mobilize more resources to be able to support these communities and have a multi-sector approach where it is not just one sector alone, collaborating with other national and international organizations, UN agencies, and also be findable and fundable. Like, create a brand, like, this is what we do, and people will come and give us. So women and girls in Panyija in South Sudan really talked about how they're experiencing GBV and that they are not getting support, and therefore actively mobilizing resources to create a safe space for the women and young girls for their mental health and psychosocial support. Next slide. Unfortunately, I can't see my pictures. I don't know where they are.
Thank you very much, Faith. Thank you very much for that very exciting presentation. Please, in the interest of time, we would just like to welcome all our presenters to come forward for a group picture, and we should take that opportunity while they are forward to still grab their faces so that during lunch or during the coffee break, we can ask questions to them and know more about their work and their researches. Please. snappy, snappy, snappy. Please look at the faces so you can further engage with them during the break. Thank you.
All right. We know that photographers always want perfect. We don't have the luxury of time. Please. All right. Thank you so much, colleagues, and thank you so much for sharing the work that you do and the research that you also do in your countries. So the last, just the announcements in terms of the breakout rooms. So we have the youth advocacy in SRHR, amplifying voices. It will be happening at the other side of this room. So when we go for tea, this room will be split into two. That side will have 2 doors, and this side has 1 door, which will be the door just here. So that's that one will be happening on that side. And then transforming mentalities, strategies, and lessons learned for young men and boys, it will be in this side of the room. So you would use this door. So that one is that side with the 2 doors, and this one would be in this room with the 1 door. And then downstairs, we would have the Bongol Inya, which is downstairs, as I'm sure colleagues know these rooms already, and then the Bongol ballroom, which is also downstairs. And there we have men care, so SRHR in the caregiving, and dealing with opposition, which is happening all downstairs. At 2 o'clock, we would reconvene in this room, every one of us, for the closing discussions. So we'll come back to this room at 2. I know that not all of the colleagues who are here will be in the room because they have other engagements, but for those who don't have that engagement, let's all come back to this room at 2 o'clock for the closing. And for the other colleagues in the room have received invitations for a special closed session. If you have received it, you know where the room is, please go down to that room. Thank you so much and enjoy your coffee.